Complex digital work, nail reconstruction. So, digital deformities continue to be a common problem among many patients who present to foot and ankle specialists. The severity of the deformity kind of helps us determine which treatment approach to take. So, when conservative treatment fails to eliminate complaints, surgical correction remains a good treatment option. So, for this week's topic regarding complex digital work, I will be discussing nail reconstruction. So this is a picture showing the basic anatomy of a nail. A nail is produced by living skin cells in a finger or toe, and it consists of several parts, including the nail plate, which is the visible part of the nail bed, which is the skin beneath the nail plate, the cuticle, which is the tissue that overlaps the plate and the rims of the base of the nail folds, which are the skin folds that frame and support the nail on three sides. Um, the lunula, which is the whitish half moon at the base of the nail, and the matrix, which is the hidden part of the nail under the cuticle. So fingernails grow from the matrix. The nails are composed largely of keratin, which is a hardened protein, and as new cells grow in the matrix, the older cells are pushed out. The average growth rate for nails is about 0.1 millimeters each day, and the exact rate can change based on factors like age, sex of the individual, and the time of the year. But fingernails actually grow faster than toenails. It's also important to be aware of the growth mechanics of a nail. It's interesting because the posterior cells go superficial and the distal cells stay plantar. So based on those mechanics, it can kind of help you better identify a lesion if presented on the nail. So what is nail reconstruction? Toenail reconstruction is restoration of a previously damaged nail and is essential for both aesthetic appearance and function. So for small area defects of the nail bed grafts may not be necessary, but for large area defects of the nail bed, primary closure is not feasible without a graft. There are several diagnostic and therapeutic indications for nail reconstruction. Diagnostic indications include performing biopsies on the nail bed and nail matrix, or exploration while looking for pathologies. Therapeutic indications include traumatic nail injuries, ingrowns, chronic onychomycosis, tumors, and chronic paronychia. So traumatic nail injuries can occur from a blunt or sharp force to the nail plate and surrounding folds, violating the structural integrity of the nail bed. The force of the injury, as well as the hemorrhagic response, can separate the nail plate from the bed, which is causing traumatic onycholysis. So if the force is strong enough, the proximal margin of the plate will separate from the matrix under the proximal nail fold and will elevate through the nail fold. So this disrupts the seal of the cuticle and can actually expose the underlying tissue to bacterial contamination. So if greater than 25% of the nail plate has been avulsed in a way to disrupt the proximal medial or lateral nail fold with the bed, then a significant nail bed laceration is likely. So this classification right here is used to describe the traumatic nail injury and treatment based on the zone injured. So zone 1 is distal to the distal tuft, and an injury here can be treated with local wound care if there's no bone exposed, or a skin graft or flap if bone is exposed. Zone 2 is distal to the lunula and is treated with a graft or a flap. Zone 3 is proximal to the distal lunula margin and usually requires a partial digital amputation. So regarding nail bed defects, there are various treatment options such as healing by secondary tension, composite grafts from a severed segment, dermal grafts, nail bed grafts, and nail bed grafts from the big toe, local flaps, and microvascular free nail transfer. And this just says right here that it is important to keep in mind that the reconstructed nail bed should minimize the unique original characteristics of the nail bed to minimize any deformities and future complications. But for the purpose of this presentation, I will be focusing on dermal grafts used in traumatic nail injuries. So thin is a type of split thickness dermal matrix graft and is composed of a porous matrix of highly purified cross-linked bovine type 1 collagen and glycosaminoglycan. This matrix provides a biocompatible interface that provides a protective environment during healing. The acellular dermal graft has been used as an effective skin substitute for burn patients as well as in complex reconstruction of full thickness wounds. The major advantage of using this type of graft for reconstruction of nail bed avulsions is the fact that there's no donor side morbidity that's usually seen in full thickness nail bed grafts. And another advantage is that the dermal graft can be used to reconstruct multiple nail beds as needed. So as mentioned before, partial avulsion lacerations of the nail bed with loss of nail plate adherence can surgically be treated with a split thickness nail matrix graft obtained from the same nail bed or from the great toe. So following the initial trauma, the nail plate is removed to evaluate whether the nail bed injury requires reconstruction or if instead it is primary repairable. The wound bed is appropriately irrigated and debrided. Once the wound is thoroughly clean, the sterile matrix of the nail bed is reconstructed using the single bovine dermal matrix. Then the dermal matrix layer is secured over any bulk graft to the surrounding intact tissue using dermabound adhesive. A synthetic nail plate is then sutured in place to protect the repair. The synthetic nails are then removed between 4 and 6 weeks following reconstruction, and patients are followed and monitored for evidence of healing, infection, and nail adherence. So this was a relevant article I found by David K. Fiedler titled Nail Bed Reconstruction Using Single Layer Bovine Acellular Dermal Matrix. And the purpose of this article was to present an approach to treating nail trauma injuries using the single layer bovine acellular dermal matrix grafts. So suitable patients are those who sustain nail bed avulsions or crush injuries with loss of the sterile matrix to one or more digits. So this study included a series of patients who sustained severe crush injuries to their fingertips with partial avulsions of the nail beds, or who underwent reconstruction using the single layer bovine acellular dermal matrix grafts. They found a strong correlation in fingertip injuries with nail trauma, and that the primary repair of nail bed injuries results in 90% good to excellent results with the use of an acellular dermal matrix graft. Therefore, using these type of grafts for reconstruction of traumatic nail bed avulsions represents a promising application and treatment option for those type of patients. So these are just some benefits of toenail reconstruction. The reconstructed nail looks and feels like a natural nail. It improves confidence. The new nail is actually flexible, so it can move naturally as the previous nail did. There's no aggressive chemicals involved. The natural nail and the nail bed remain undamaged. The new nail can have polish applied as a natural nail, and the new nail can be treated in exactly the same way as the previous natural nail was. Okay, so finally, I will conclude this with a case presentation. This is a 56-year-old man who sustained a crush injury to his right thumb. In figure 1, you can see a crush injury to his right thumb distal phalanx with a loss of portion of his nail and nail bed injury, not responding to primary repair. Figure 2 shows an autogenous fat graft from the distal radial side of the patient's forearm that was used to add bulk and contour to the missing tissue before reconstruction of the nail bed with the dermal matrix. And figure 3 shows a dermal matrix layer was secured over the fat graft to the surrounding intact tissue with the dermabound. So in figure 4, you can see a synthetic nail plate that was sutured in place to protect the repair. And in figure 5, you can see the autogenous fat graft donor site was closed and the patient was placed into a thumb splint after surgery. And then in figure 6, the synthetic nail was removed at 6 weeks following the reconstruction procedure. And in figure 6, 7, and 8, upon follow-up at 9 and 19 months after surgery, the patient was doing well with a new nail plate growing in place with excellent appearance, adherence of nail, and function of his thumb. So these are just my sources, and that concludes this presentation. Thank you.